Mitochondria don't stay in their lane. When you get injured, the mitochondria go from one place to another and they go where they're needed. It's who knew?
Aside from your marker that came from a textbook written in 1957, I would like to know what other value you are basing this timeline on.
It's not like drugs work for nerve pain. There is no thing that works for the thing that is the easiest for us to treat.
When you become a really good listener, the frequencies, the ideas, the hypothesis, it comes to you. It's about listening with your ears and your hands.
In order to treat the vagus, you had to quiet down the limbic system. So his limbic system was off the charts, which would keep the vagus off from the day he was born.
Sometimes you have to put in the good before you take out the bad.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues, unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
Quantum Biology Forum was a trip.
We have so much to talk about.
Oh yeah. Go.
No, you go. I'm just going to sit here and drink my tea that John Sharkey brought me this mug back.
There you go.
So I'm just going to sit back and drink my tea and listen to you.
Let's see. I got back from DC on Wednesday night. I found out, I think we talked about this last week, that mitochondria move, that we have.
You and I talked on the phone. I can't remember if we talked on the phone about this or if I talked with everybody about this. But I think we need to repeat this because moving mitochondria is interesting.
It's a completely novel idea. And the graphic the speaker used was mitochondria on a freeway going the wrong way. So you had the cars coming this way and the mitochondria, it's one side, and it said mitochondria don't stay in their lane. When you get injured, the mitochondria go from one place to another and they go where they're needed. It's who knew? And they're talking about mitochondrial transplants in people who have mitochondrial genetic defects. So there's this child, I guess he's about 6 or 7 now, who has mitochondria that don't work. He can't walk. His muscles, where all the mitochondria are, brain, the heart, the skeletal muscles, so he has trouble with all of that. And they're actually talking about, because the mitochondria don't have immune markers, they're doing mitochondrial transplants in animals now, and people are next. And it's, whoa, wait. Let's go back to mitochondria move. And so when I was at this meeting, I thought, sure, we talked about this. I was at this meeting. I was the only one there that didn't have a PhD plus 2 or 3 other, right? I'm the only clinician in the group. The rest of them are researchers. And so I've just met this whole layer of people, that researchers that are interested in what we do and say, have you done this, that, or the other thing? And it's no, because there's nobody that's going to make money if we find out whether or not frequent or how frequencies do this. Oh yeah, there's that. Right. So then we talked about the foundation and the American Academy of Resonance Medicine, and people say, well, that's the thing, just keep raising money for that and we'll do research, and then nobody will care if it produces a patent, or you just pay for the imaging and the basic science and go from there, and then everybody will be happy. And it's really, it works like that?
I think so much has changed from when you first started doing this, right? I think you're used to having the skepticism, the resistance, the something. If I just open up my Instagram feed, it's filled with ads with lasers, red light, sauna, UV, infrared, near and far, right? Light mats. We're evolving into this, I think, very holistic, going back to basics time. So I feel like it's not coming full circle, but
Sorry.
Kevin's iPad just went berserk. Okay.
it scared me. I was like, where? But from the 1920s, when these osteopaths were coming up with using things like light and frequency and laser and all that stuff, and then we tell the dramatic story of what happened. But it feels like there's this resurrection happening right now with all these things, and people are talking about it with more open-mindedness. I think we want to get back to that holistic, get away from the drugs, get away from the surgeries. So I think it's such an exciting time for what we do.
Well, and we're lucky in a way because there's no turf. It's not like drugs work for nerve pain. There is no thing that works for the thing that is the easiest for us to treat.
Right.
There is no thing. Implantable vagal nerve stimulators,
Yep.
great. And it's a surgery, and it has a fair amount of risk, and it has a fair amount of side effects, and they only work for about a year and a half, and then the body figures out a way around it. And it's so far, I had surgery on my hand a week ago, and there's one stitch that was just, the knot was, the skin was growing over it. And so yesterday, I emailed my surgeon and said, is it okay if I go to urgent care and get this stitch taken out? And he said, sure. I get to urgent care, and the young man, the doctor that's there, he says, sure, but he doesn't say, sure, you can take the stitch out. And it's not an urgent thing. And you can't take the stitches out for 10 days. 10 days. It's been 5. Look at my hand. The skin is growing over all of the stitches. But it says I can't take them out for 10 days. And it's okay, fine. So I went and had sushi. And then I came home and I disinfected a little pair of scissors.
Yeah.
And we cut the knot out, and then disinfected a little pair of tweezers, and then we pulled the stitch out, and my hand feels so much better. But it's like they don't get it.
Right.
We're just not, they are taught to believe what's written as a protocol instead of using their eyeballs and their brain.
I have a couple things to add. And those of us who are in sports and working with professional athletes know there's this pressure to get somebody back faster than what that timeline is. As long as it's safe, we're always pushing that boundary. And you will get some of those doctors that are just fixated on this timeline that has no real objective value other than it's a timeline that they found somewhere. And I used to be very compliant with that timeline, but I've learned through the 25 years in practice that I can use some curiosity, and I feel brave enough to go toe to toe and say, okay, this patient has no bruising, no swelling, has full range of motion, has strength, has sound orthopedic testing in all of these different ranges. Aside from your marker that came from a textbook written in 1957, I would like to know what other value you are basing this timeline on. It's respect. I'm being respected. I'm asking a respectable question. I'm not trying to be a smartass, but more often than not, I will stump them on that because there is no other objective finding. Dr. Massey talked about the 16-year-old at the advance that had healed their ACL without surgery. And he's doing this from afar. And the PT is saying, I don't understand it. He has all these markers he's meeting this criteria. These tests are strong. And he's, let's just go with it. But that's having an open-minded surgeon that's willing to look past the timeline.
Yeah,
And
it's just amazing.
But it's to your point, like there is that. I feel like we have a lot of open-minded patients right now. Again, going back to that holistic, let's try these different modalities. They're all safe versus no, that's impossible. Things don't heal that quickly. But it did.
Yeah, except it did. I have to say, let's see if I can find the text. I don't treat autism that often. And we know from Steve the dad that just the plain concussion protocol worked pretty well. And this lady she came in first and told me her son's history. And he is profoundly autistic, like profoundly, and OCD, and all the things. And they've had brain scans, and so they knew what parts of the brain were overactive. So the basal ganglia, the 988, the limbic system, whatever 981 is, and then the anterior cingulate was underactive. So I took his scans, and there's this experimental frequency that's no longer experimental, because the first day I treated him, I think we treated for about 20 minutes because I'd run a frequency for 5 seconds and he'd make a frowny face. Okay, moving off from that. We always knew we could go back to quieting the limbic system and quieting the basal ganglia, because he's way dopamine, like over the top dopamine. And so we knew we could do that. So I nudge into another frequency. And then, so when he went home that first night, his mom said the difference was profound. He was quiet. He was just easier. But the next morning he woke up and he was back to baseline. They came in yesterday and she had his brain scans and she gave me that information. And then we took the things that were overactive, the basal ganglia, the limbic system. What on earth is 981? Don't remember. Anyway, and then I ran quiet the medulla and then increase the anterior cingulate to increase the quieting effect of the anterior cingulate on the rest of the overactive parts of his brain. And so I've got Dave Burke and Ben Catholi by text, and we're texting, and Ben used 981 for the anterior cingulate. I'd never used it before. So I did increased secretions in the anterior cingulate, and quieting the anterior cingulate, that was at whatever 983 is. That one needed to be brought up. The kid fell asleep. We treated him not for 2 to 3 minutes. It was like 2 hours. He slept like a stone the whole time, and the body stopped twitching.
Wow.
And when he got up, his gait was smooth. His behavior, all the twitchiness and the almost spasticity was gone. He was verbal. He was making eye contact. He wasn't making scrunchy faces. And it's okay, that's good. It's
And
hyperactive
this was
limbic,
when?
hyperactive limbic system, thalamus, basal ganglia, dysregulated medulla, non-functional vagus, and 81 and 983. So increase secretions in, I've got to find out what 983 is now. That's going to drive me crazy. I knew it yesterday. 983. Oh, the prefrontal cortex, duh. The prefrontal cortex tells the rest of the brain to just calm down. It's getting, when he focuses mentally, he can cook. He can use a laser lathe to make wooden tables. When he focuses mentally, all of these other physical aberrations just go away. The excess of dopamine stuff just goes away. So it's okay, how do you get the cortex to work? You have to start with the anterior cingulate because it's the brakes on the rest of it. So it was like playing an organ, and the organ you were playing was the brain. It was just yikes. So maybe I'll have a case report for next year. It's definitely going in the advanced more now. Again,
That's fast. So when did you treat them? Was just recently, today?
yesterday and the day before. The first day he was so agitated, and I didn't have all the scans that she'd had done. So the second day she had the scans, and it's okay. I knew what to quiet down and I knew what to bring up, and it worked. And instead of treating him for, I don't know, 12 minutes, we treated him for 2.5 hours. It was crazy. Okay, fine.
And will you treat them again this week?
Oh, tomorrow
Okay.
and Friday. Yeah.
I wonder how long the effects are going to last. That's always my question.
The first day it lasted all night, 12 minutes of treatment, and it lasted all night. But the next morning he was back to baseline.
Yeah.
We treated him for 2.5 hours. He was a whole different kid when he stood up, and he's 25, I think. And so we'll see what he's like tomorrow. And mom says they'll get a custom care. And I said, we can program him for individual frequencies. She said, no, I'm going to get the list from you. I'm going to buy a precision care and a converter, and I'll treat him that way. That'll work. Okay, sure. Okay.
That was my question. Magnetic converter you used?
I used wet towels on him. It didn't bother him. I went from his neck to his abdomen. He's anaphylactic to eggs, sesame seeds, and nuts. He's gotten so he tolerates eggs now, but he has incredible GI problems. His vagus nerve just doesn't work. And so we had to, in order to treat the vagus, you had to quiet down the limbic system. So his limbic system was off the charts, which would keep the vagus off from the day he was born. He was like this when he came out. And it's yikes. And then he got vaccinated, which didn't help. But they gave him, that was the other weird thing. He wasn't urinating. So their solution was to give him gentamicin.
Which is?
It's an antibiotic that is ototoxic. So I treated towards the end, when we're running out of things to treat, I treated his inner ear for toxicity, necrosis, because gentamicin does things that are not good to the inner ear. And
Which is 44?
44, yeah.
Yeah.
So I tried that. We'll see if that does anything. At the end of it, we could always go back to the basics, which was quieting the limbic system, quieting the basal ganglia, quieting whatever 981 was, and then bringing up the anterior cingulate. And that made it possible to treat the vagus. And then his small intestine. Oh, I know what we started with. We started with balancing the energy centers.
Neat.
His mom is pretty energetically sensitive. And I asked him if he was. And
Yeah.
she said, I think so. There are times when he sees things that probably are energetic rather than physical. And he'll talk about them. So, okay, let's try the energy centers first. She said,
Yeah.
I like that. So we did the balancing the energy centers, then we went after the brain. And balancing the energy centers, you just see his body relax. It was amazing.
Yeah, and I find that I think we are starting to talk about that frequency and those pairs obviously a little bit more. You were talking about solfeggio and using the balancing the energy centers that way, which I'm grateful for. We added that to the advanced this year, which
Yeah.
I am grateful for. It was time, I think, to add that. I've always liked that frequency just myself. It feels good. It's like the constitutional factors. I feel like it's grounding, but it works. It just feels different. And I can't explain it other than maybe it's just things feel more balanced and you just feel more regulated, safe in your body. And we talk about using that sometimes at the end of a treatment, but I think it's very valuable to think to start that way sometimes.
No, I agree. I think you're right. It's sometimes it's like the energetic body has to be balanced
Yeah.
before the physical body can catch up, before it's okay for it to do that.
Yes.
I,
And it almost reminds me of Dr. Roger Billica. It's very simplistic. Sometimes you have to put in the good before you take out the bad.
true.
And it was like when he said that, I was like, okay, everybody pause. Everybody, let's just let that just sink in. And he wasn't talking about frequencies when he said that. He was talking about, I think it was nutrition and supplements or even maybe medication to support somebody who's depleted. If you just look at that kind of overarching message, it's not always about pulling out scar tissue or smushing something. Like sometimes it's about giving the system something first before you can even think about unraveling it. Sometimes supporting it gives you more information.
Yeah.
And I had a very long run on Sunday, 2 hour run. And 2 hours is a long time you and I talked about this. You go into this meditative state. It's not a trail run, it's a paved path that I do. So I don't have to be hyper focused on my footing. And I love it because I get to unravel and think about so many things. And when I think about how much my practice has changed, the way I treat, of course, we talk about the patient history and just thinking about all the different tissues, but there's an application that completely changes once you become a little more proficient with FSM. And that is the listening. That is, I'm not going to tell the tissue anything. I'm not going to squish it, poke it, prod it, strip it, laser it, shockwave it, right? Like if you think of all those modalities, we are telling the tissue how to behave. And it's more about listening. What is this tissue telling me? What is this person telling me about their story? And when you become a really good listener, the frequencies, the ideas, the hypothesis, it comes to you. It's about listening with your ears and your hands and slowing things down. Like
Yeah.
I love that.
It makes it so much fun because every patient is different.
Yeah.
And there's another patient I had this week, Monday and Tuesday. She definitely had a TTH kind of history,
Right.
but she had an auto accident in 1980 1986, where they had to cut her out of the car. Her foot was crushed, and she's had 32 or 36 surgeries, and they did multiple surgeries on the foot. And then the accident was 1986. They're working on her foot because it's all smushed. And somebody finally looks up and noticed that her head was bleeding. And so she says, I pull out pieces of glass. I still pull out pieces of glass out of my skull, right? And so she has phantom limb pain in the missing. I found out you can't call it a stump now. You have to call it a residual limb. I learned that on Monday.
Okay.
And so she had phantom limb pain, but the biggest problem is she has neuromas in her residual limb that I thought I had been used to medical malpractice, but this was a whole new exploration. They did skin grafts, and she said, oh, this part of my leg hurts. They took a graft from here and a graft from there, and I just can't hardly touch them. They took the grafts from the cutaneous branch of the iliohypogastric nerve and from the lateral femoral cutaneous nerve. Now, I worked in a burn unit for a week, but when they do grafts, they do the grafts where there aren't superficial cutaneous nerves, because if you cut a nerve, you get phantom limb pain. So there was that. So if you touched either the iliohypogastric nerve, like right just above your pubic bone, and then down on your labia, two different superficial cutaneous nerves, her foot that wasn't there sizzled and hurt. That was interesting. I did a sensory exam, and the first thing I tested was soft touch. And I figured that her phantom leg would hurt. But I started up around her bra line, and soft touch was exquisitely painful from T5 to her knee on the amputated side, and then sharp touch on the other leg. She said, oh yeah, I have disc bulges at L4, L5, S1. Aha. So she had nerve pain from a disc on her right leg, and there's no nerve that goes from T5 to your knee. The only person I ever treated that had that pattern was the construction guy in Taiwan that fell asleep on his back and had a thalamic stroke. And I said, tell me, in all of the imaging that you've had, did anybody ever do an MRI of your brain? No, actually. You had a thalamic stroke. You had a brain bleed. That's the only thing that matches this pattern. And the only reason I know is that one guy back in Taiwan. The thalamus has quadrants, and this lower quadrant on that side of her body is hypersensitive to soft touch as well as to sharp. Soft touch is worse. And it's like CRPS, but in her brain. So I ran 40 and 89, and we got it down from the bra line down to these cutaneous nerves where they did the skin grafts. And so she has a whole different kind of thalamic pain there. She has phantom limb pain in the cutaneous branch. It's just, I, it was really hard. So you remember the things I can't teach you, that story?
Yeah,
That's what I went through Monday.
right.
It was just, it was too much. It was just, I, okay. So yesterday we ran TTH.
On you too.
Uh, Monday night, because I haven't run my nighttime program, which is concussion in Vegas, ever
Right.
since my surgery.
Yeah.
It's my hand is on its own. I have to run the Vegas. So my blood sugar came down and my HRV tripled,
Wow.
went from 26 to 67. Okay,
Wow.
that's interesting. That's because I got to run my Vegas for the first time in a week.
Yeah.
It's the things that we can treat, those two patients.
Yeah.
Who does that?
You.
Even thinks about that? Yes.
Right. I always want to share my stories, and then after you you come up with those two, I'm like, I treated a hip labrum today. That was pretty fun.
That was fun. That's important to the guy with
But
the hip labrum.
the hip labrum story, I would want to share this because I think it's important to share your side of the spectrum and then my side, and then everybody that's listening is somewhere in between. But when you're treating a triathlete, so an Ironman triathlete who's done, I think, 10 of them,
Ah,
she's a world-class triathlete who has, quote unquote, a cranky hip that she is just getting heavy-duty manual therapy once a week to try to maintain. And so this is the part of going, how's that working for you? If you're going once a week and you're spending X amount of dollars and it's not getting any better, something is wrong. Now, she has a custom care because I have been working with her for years, but I don't think he's using it to its full potential because they're used to running obviously delayed onset muscle soreness and the workout recovery and all the things and concussion in Vegas for sleep. But something that was going on with her hip, and after an evaluation and exam, you could see that the glute med, glute min, TFL, these abductor, like for a runner, triathlete, swimmer, we have to think about what their movement pattern is. And most of it is
yeah,
in the sagittal plane, right? It's flexion extension.
yeah.
So, yes, she has strong glutes. She has strong hip flexors. She's swimming and she's a rock star on the bike and a rock star in the swim. Now, running is her weakest part, and that's where her hip starts hurting. So, again, we're hitting pavement, and where she's pointing to the lateral hip, my first thing is how much lateral movement do you do? Hardly any, right? Like
Yeah.
everything she does is in the sagittal plane. So those lateral rotators, the lateral stabilizers of her hip become fatigued because they're there to just be the supporting cast of characters. Now, is it even possible for somebody who's near 50 years of age, who has been racing Ironmans for the past 20, 25 years?
Oh my
Let's think
goodness.
about what her labrum looks like.
Oh, I'd rather not.
So she's, I don't want to get imaging. I don't want to think my labrum's torn. I'm like, let's not go to the fact that you have a torn labrum, but let's meet each other in the middle. Is it possible that you have at least micro tearing happening in your labrum?
It's frayed on the edges.
Right. And that is normal for somebody who has the mileage that you do. So I think a part of it is be careful with our words. We don't want to say you have a torn labrum. We have no right to say that. We have no right to say you need to stop racing. Let's meet the patient where they're at. You're going to keep running. Let's keep you running as long as you can. That's safe. And so I could have put my elbow in her hip. I could have done all these different things that she's probably getting done. But let's run 124, which is our torn and broken, or what we call repair and heal, right? Let's make you a repair and heal protocol that's just for your hip that you can run at night or after you train that just focuses on those internal structures, right? So 3 machines, an hour and a half later, she goes to the restroom and comes back and that was amazing. I'm like, your pee? What? Talk to me. And she's just sitting down in the toilet. What a different experience that was. just that flexion, it's like a squat pattern, right? When
Mhm.
everything becomes balanced, it's not so much of a struggle. And I didn't realize how painful even just lowering down into a chair or onto the toilet used to be, right? We're not fixing autism, we're not fixing thalamic strokes, but if I can get somebody, whether it's an Ironman athlete or somebody that just needs to sit down on the toilet, to do that differently by just looking at movement patterns, doing an assessment, and having conversations.
It is as thrilling. I mean, what I did with those two patients in the last 2 days, it's as thrilling to fix it so somebody can put a cup on
Yes.
the second shelf in the cupboard
Yes.
by getting rid of this subscap without
Yeah.
having them reported to the Geneva Convention. It's you take two machines and do that. And
Yes.
the labrum, it's
Yeah.
the I think there's a what do you call it? It's kind of like Chinese water torture, where you have just pain every time you do a
Yeah.
normal everyday activity, and it just wears on you. And
100%. And the athletes are so used to blowing through the stop signs that they don't even realize that dull, constant, death by a thousand cuts sort of pain.
that's the
They're
word.
waiting for that big pain when they run or after they run, so that when you can tone it down or turn the volume down on it, and then they do something like sit down in a chair or put the cup back, that's what they're like, I can't believe I can do that without pain again. And that's what makes our job so rewarding and fulfilling. And yeah, you have the patients that you take that negative story deep within you because it's
Yeah,
hard to not, because we listen. We listen like nobody else listens.
true.
And we don't take surface garbage can diagnoses to heart. We
Oh,
take them with a grain of salt.
I loved the fact that she came in with a diagnosis of neuromas. She had neuromas in her residual limb.
Let's talk about that for a minute. So, for the lay people that are listening, can you explain that a little bit more simplistically?
A neuroma is like a Morton's neuroma is in between the two toes, and it's the nerves. There's nerves that run in between your toes, and there's a nerve that gets tangled up in scar tissue,
Yeah.
and that's a neuroma. This the things that they did surgically to this residual limb are beyond description. I can't even talk about them without it just can't. But let's say she's had a total of 36 surgeries on that leg. The accident was 1986. They didn't get around to amputating it until 2014.
Wow.
And after they amputated it, they did another 5 surgeries. The first surgery they did with the amputation, he she said, there's something wrong in there. They took an x-ray and there was a piece of wire in there. He was gonna, they left her tibia and her fibula in the residual part of her lower leg, but there's so much scar tissue in the nerves, she can't put a prosthesis on it. And so the next surgery took the wire out, and then they put in a bony bridge. So they put in a piece of bone from someplace else to keep the tibia and the fibula apart. And there was a problem with that. So I had another surgery to fix that mess. And then there was scar tissue in the artery and the nerve and the fleshy pad that is supposed to hold the prosthesis. I just 36 surgeries. The
Wow.
accident was doing the math,
Yeah.
1986. And when was the amputation? 2014. Wait, what? 86, 96, 86, 8. That's 18 years. 18 years with okay. Yeah. And they missed the fact that it was because she had a thalamic stroke. She didn't have a thalamic stroke. She had a brain bleed from a skull fracture that they missed.
Right.
And it's okay. So her that this conversation started with, you don't believe the incoming diagnosis. Somebody actually told her, now this is a woman in a wheelchair, and she has a tennis shoe on her remaining leg, and she touches the tennis shoe to the floor. Somebody told her that her fourth metatarsal hurt because she had plantar fasciitis.
Stop.
She's no, you can't have plantar fasciitis. No, I have plantar fasciitis because they have me rolling my foot on this ball because I have plantar fasciitis, and I have plantar fasciitis because I'm not weight bearing, and so the plantar fascia is contracting and blah blah blah. And did anybody do a sensory exam? So I used the little pokey wheel. L2 and L3 were okay. L4 was way cranky. L5 and S1 were very cranky. So I just set up one machine from her low back to her plantar fasciitis foot. And after about 40 minutes, I started wiggling this fourth metatarsal. She said, that hurts. It does. Not now. Oh, it doesn't hurt. No, you don't have plantar fasciitis. You have C4, L4, L5, and S1 nerve pain from the disc bulges in your back. Remember when you fell on your butt and bulged those discs in your back? Oh, yeah. Oh, yeah, and I'm hypermobile. I used to be able to put my legs over my head. So we had a conversation about her SI joints, and it's just like, they just told me I was hypermobile. They didn't tell me what it meant. Okay.
Yeah, I think some people in the medical world are really quick to just throw out something to give somebody without
Yeah.
anybody questioning it for some reason, which is really
Yeah.
sad. I talk about the story of when I went to a new PT for my hip pain, and he barely did an exam and just said that I had weak glutes. And then I started putting my shoes on. He's like, what are you doing? I'm like, I'm putting on my shoes. He's like, where are you going? I'm like, oh, I'm leaving. And he's like, why? I'm like, because I run 25 to 30 miles a week. I don't have weak glutes. And if that's the best that you can do, I'm not staying.
This was an
This was
orthopedist?
me going to a new PT.
Oh, okay.
And I said, I am not interested in working with anybody that's going to give me a lazy diagnosis. Yeah, tell him, Kim. But
good for you.
But that is, again, me having some mileage to be on the other side to let's talk about. And he knew that I ran that much. It's impossible for somebody that runs that much to just have weak glutes. Now, if you want to tell me maybe a certain glute muscle may be inhibited due to the fact X, Y, and Z, sure, I'll have that conversation with you. But things like plantar fasciitis, weak glutes, there's so many of them out there, tight hip flexors, like, come on. I think I just read in the Q&A or the chat, somebody, DNA had written, I had chronic hip labrum issue that resolved once we cleared up the scar tissue from a C-section. Absolutely. Like that is starting to think what's connected to what? How did we get here? So it's not just looking through this really myopic lens of hip labrum, it's thinking, when did it start? And what was happening before that? And what's the hip and pelvis attached to? Everything is connected to everything. So you have to start just opening up your viewpoint a little bit. At the very least, ask more questions. We had in Arizona, when we were doing the shoulder practicum at the sports, we had somebody who had a quote unquote fresh kind of labral injury dating back 3 months. However, none of the joint labrum frequencies were working. And as you unpack the story, the shoulder had been an issue for 25 years. This was an athlete that had multiple injuries, trauma, and it was the trauma frequencies that started making everything relax. It was that shoulder that feels like it's shrink wrapped. He was very muscular, but there was no give, like nothing was happening. And yes, I understand he has a torn labrum. We have a diagnostic image reporting saying that this is happening, but you don't stop there. You don't just say, oh, this has to work, and I'm just going to leave it on here and poke even harder because I know the labrum's torn. The patient will tell you, yeah, but the shoulder was hurt this year and it dislocated then, and I had this injury from there. And so the repeating word that we kept hearing was trauma, multiple injuries. So let's go back to the source. How did the scar tissue happen? And similarly to how this person was talking about how does clearing up C-section scar tissue affect the labrum? What's happening in the pelvic floor? Where does that pull on? Like, how does that change and adapt the tissue?
And when you have a C-section, if you look at the way the anatomy works, there's a little, I, I would call it a groove, but it's a space where they do the C-section and you have every drop of blood has fibrocytes in it.
Yeah.
So you do a C-section, and there's even the guy, if the guy who's supposed to be suctioning up all the blood, just all he has to do is mess a little bit, and the blood flows down and tightens the internal rotators.
Right.
If the internal rotators are tight, then the external rotators have to tighten up to keep the thigh and the hip balanced. And that's going to put pressure on the labrum. So what's the connection between I had a C-section and then my labrum got sore?
Right.
So you have to treat the scarring in the nerves and the adductors and the torn and broken in the connective tissue for the piriformis and the gemelles.
Right.
And then if they did that with a C-section, it'd be worth checking the psoas.
Yeah.
So you loosen up everything that's causing the hip joint to jam and smash the labrum. So you loosen all that up. The labrum almost fixes itself. Once you fix what's causing the trauma to the labrum, in the hip anyway, and the shoulder too, but once you fix what's causing the trauma, then fixing the labrum is like easy.
Yeah.
It's just not that hard, but you have to think when you have to ask.
You have to ask.
When did it start?
And so many times when we're going through patient history and we talk about you hit how many pregnancies have you had, how many births have you had, what type of births were they? We just, I don't know, like we see it, but it doesn't resonate, for lack of a better word. And so you think, okay, what could potentially happen with cutting, with healing, with reorganizing? Like even what happens, organizing, reorganizing, just growing a baby. It'd be really nice to think that all of our organs just go right back to where they were. Nobody warned me when I left the hospital after having my first baby that I was going to leave looking just as pregnant as I did walking in. It takes time for everything to organize itself and go back. And it's never going to go back the way it's supposed to, let alone after a C-section.
And they don't, they don't tell you that there's a hormone that starts being produced about 4 weeks before you give birth that makes your pelvis just go sploosh. Like it loosens all the ligaments in the pelvis specifically, but you have ligaments every place else. And I was 7.5 months pregnant and I sprained my ankle, and my ankle has never been the same since. She left out the part that she was 7.5 months pregnant. Just said, I sprained my ankle in 1998. Okay, what else happened in 98? Oh, how many kids do you have? I have 3 kids. And when were they born? There was one born in 98. Did you sprain your ankle before or after you had the kid?
Right.
Oh, actually, I was about 7.5, 8 months pregnant when I sprained my ankle. Okay.
And it's not their fault they don't give the complete history. They just don't understand how much we are trying to connect dots that nobody else has ever tried to connect before.
Yeah.
And the questions, to me, are such an exciting part. And I always talk about like the crime scene investigator. Like people are like, you missed your calling. You should have been like a private investigator. I'm like, oh no, I use those skills in my job all the time because a biomechanic exam is one thing, but to pull the pieces from a biomechanical exam or assessment to the history is what I love. And that's what keeps me up at night in the best possible way of, especially when you have those cases where you get close, but you can't quite resolve it. And I used to take it to heart, but now I'm just thinking, okay, we're just missing something. There's just a story that hasn't been told yet. And maybe using 7 machines will get that patient dwarfed enough that they're going to spill the beans and I'll be able to like figure it. That's what I think. One day they're going to tell me. Yeah.
Yeah. Or I just go back and ask again. I
Right.
already told you that. I know, but there's a piece missing.
Yeah.
And the nice thing is that we can also treat more than one thing at a time. I never work on somebody's shoulder without at least 2 machines. One
Right.
that runs
Just
40 and 396,
yeah.
actually 3, 40 and 396, treat the disc repair, but also scarring in the nerve. So if you're treating inflammation in the nerve and scarring in the nerve at the same time, you don't have the scrunchy face
Yeah.
that you have when you.
My analogy when I call it like the dueling pianos, right? When you have the scarring and the inflammation running at the same time. I liken it to going to the dentist and the dentist is drilling and then you have the hygienist with the spit sucker at the same time. Like it's just one is doing something and then the other one is just like clearing out the debris.
Exactly.
Yeah, and they're using multiple machines is not only just a convenience, sometimes it is absolute.
She froze.
Yeah, she did.
Wow.
They knew it was 4 o'clock.
It's 3:59, but her internet
I
froze.
need to have a few machines running at the same time,
Yeah,
You're gonna have to repeat
right?
that.
It's just, oh,
it's magic.
yeah.
That's so cool.
I hope we didn't have any questions. We're almost out of time. I think I saw a couple comments here.
Yeah,
Those are all done.
belief is 981 is the cingulate gyrus, and then 983 is the prefrontal cortex. So the cingulate, I think, makes dopamine as part of that pathway. I think that's what I did. Yeah, so 981, we had to quiet that and the basal ganglia and the limbic system because they were all jacked up.
Right.
Then had, yeah, and then bring the prefrontal cortex back online to quiet things down.
Amazing.
On a side note, just went to Japan. I was shocked to experience my foot near my toes feeling cold when using a bidet. I assume that before that your foot was numb. Is that correct? Why is it blinking, Kevin? That's It's blinking. There we go.
It is.
4 o'clock.
And
What happened? The
it,
usual
you know,
way.
it's the vortex of lost time, 3 to 4 on
It
Wednesday.
is.
That's what I just call it. But
Yeah,
fantastic. Always
as always.
fills my brain with all the good, happy, knowledgeable nuggets that you give us. So, yay. We will be here, I think, same time, same place next week.
Yes, I'm going to be in Costa Rica. I have to get my picture taken on, what day is that? I get there on Tuesday. And okay, the appointments are on Tuesday. So on Wednesday, Costa Rica is an hour ahead. So I will be on the back porch at John and Kai's. And it's the sunny season, the dry season, so there's no rain. And assuming there's electricity, I will join you all.
Yay. And you'll have a background that most of us will be very jealous to see.
It'll
So
be really
fun. So we'll see everybody here next week.
See you next week. It's good to see you. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.